Welcome, everyone. We will be starting momentarily. All right. Okay, so hello and welcome to today's webinar, Standards of Medical Care in Diabetes, 2022 Update for Early Career Professionals. This session is brought to you by the American Diabetes Association's Focus on Fellows Early Career website series. Thank you to those that have attended our Focus on Fellow sessions in 2021. And for those of you that are new, we will be providing additional information on how you can join the Focus on Fellow program to get access to great sessions like this. Please note that today's presentation is geared towards early career endocrine and diabetes fellows. However, if you are not one, we welcome everyone who is joining us today. My name is Noha El-Sayed. I will be moderating today's program. To share a little bit about myself, I am the Vice President of Healthcare Improvement at the American Diabetes Association. My role oversees the standard of care guidelines, the consensus statements, professional education, and quality improvement. Outside of ADA, I'm a practicing physician in Boston, and I'm faculty at Harvard Medical School. None of this today would be possible without the guidance of ADA's Early Career Advisory Group. We would like to thank the members for all their hard work to develop today's program. We are also very grateful for the support of the Leona M. and Harry B. Helmsley Charitable Trust, who have made this meeting a possibility. Focus on Fellow offers a career development program for early career fellows who treat diabetes and its complications. We have several upcoming early career webinar sessions this spring. We're including the registration link in the chat. For our next session, it will take place on January 21st. It will be focused on best practices for job interviews, so we don't want anyone to miss it. Our main Focus on Fellow program will take place at the ADA 82nd sessions, scientific sessions in New Orleans this June. We're hoping for an in-person. Attendees who participate in Focus on Fellow programs will be eligible for complimentary registration to the scientific sessions. If you're not already a part of our Focus on Fellow program, we encourage you to join. This is a free program. Visit our website. The link will be in the chat for more information. And we just opened our application process. So if you're interested, please go to the link that is provided in the chat. By joining the Focus on Fellow program, you also become a professional member of ADA. This free ADA membership will provide even more opportunities for you to network and grow professionally. The ADA membership includes a variety of professional member benefits, including meeting discounts, WIN ADA, which is the Women's Interprofessional Network, interest groups, Diabetes Pro member forum, professional journals, members-only webinars, a directory, standards of medical care in diabetes resources, and Diabetes Pro quarterly. As you can see, you will have access to a lot of great resources as an ADA professional member. And now we will transition to today's program with Dr. Robert Gabay presenting on the 2022 updates in standards of care geared towards early career professionals. If you have any questions as we move through the presentation, please type them in the Q&A. The chat, we can definitely interact there, but if you want your question not to be lost, kindly use the Q&A box in your control panel. It should be below the screen. And now I have the privilege of introducing Dr. Robert Gabay. Dr. Gabay is the Chief Scientific and Medical Officer at the American Diabetes Association, where he leads ADA's efforts to drive discovery within the world of diabetes research, care, and prevention. Previously, Dr. Gabay served as the Chief Medical Officer and Senior Vice President at the Joslin Diabetes Center. We are excited to have Dr. Gabay presenting on the 2022 updates of standards of care in diabetes. And with that said, I'll turn it over to you, Dr. Gabay.
Thank you so much, and thrilled to be here. Appreciate all of you joining, and so welcome. Let me pull up my slides. Just give me a moment, and we'll get started. So, first, I want to particularly thank the early career and welcome the early career people. This program is really one of the most important things that the ADA does. You are the future of our world of diabetes, and we want to do everything we can to support you. And so for those of you that have been involved in the past, thank you. And for those that have an opportunity to apply, please take advantage. So what I'm going to talk about today is to share updates on the 2022 standards of medical care. And maybe just to level set us, I'm going to start with a polling question. And so there's you'll see a poll pop up. And here's the question, and I want you to be honest because there's no wrong answer and it is anonymous. So have you read through the 2022 ADA standards of medical care? Be honest, yes or no. There's no right answer here, but it just gives me a little bit of a sense of who our audience is. And so please answer your polling question, and let's, we should be able to pop up some responses as we've got. Okay, good. First of all, thank you for being honest. The majority of you have not, and so that's perfect because that's why we're here today. So I'm glad that we'll have an opportunity to work through what is new. So I am gonna, oops. My screen freezing. Okay, so first let me just give you a little bit of background on how the standards of care are created. So this is a yearly document that comes out, and there is a group, the Professional Practice Committee, that reviews the entire scientific literature of what's happened in diabetes management, treatment, prevention in the last year, goes through all of that literature, compares that to what the recommendations are, and then identifies areas where we may need to make changes. That Professional Practice Committee, which is an amazing group of really multidisciplinary individuals that are experts in their field. So we have adult endocrinologists, pediatric endocrinologists, primary care, diabetes educators, nurses, dietitians, cardiologists, nephrologists, really the gamut of what it takes to think about management of diabetes. That group debates all of these potential changes, rates the evidence for those changes, and then proposes the new standards that are brought to us internally as ADA staff, Nuha and myself, and then brought to the board of directors to approve. And one of the things that got started a few years ago was, even though we publish this every year, as you can appreciate, diabetes is such a rapidly moving field that within a year's time, there may be important findings that need to require updates. And so that's why we have a living standard now, where even between those yearly issues, we can make updates to the standards of care. And then as far as funding, this is independent. This is funded through the American Diabetes Association. There's no industry funding involved in the preparation of these standards. So with that as background, what I'm going to do is really try to organize the wealth of information that are in the standards of care, and it really is a wealth of information. And I encourage you to take a look, and at the end, I'll give you some easy ways to access all of that information. But I'll organize what's new, and that's where I'm going to really focus in four big themes that you'll see us discuss. First is new information about screening, really important, screening for diabetes. The second is around individualized care. The third is around comorbidities. And the fourth area that has a number of changes is around glycemic assessment and technology. And so I'll go through each of these four, tell you what's new, and then again, if you have questions, please put your questions online and we'll get to them at the end. So what are the big changes in screening? Some pretty big changes. So the thresholds for screening are, number one, if an individual is overweight or obese and over 18, and they have risk factors for diabetes, family history, et cetera, they should be screened for diabetes right off the bat. If they have none of those risk factors, everybody should be screened starting at age 35. And that's a big change from what used to be 45. And that's really based on the fact that we know that people are developing type 2 diabetes at younger ages. So that's one big change around screening. If someone has a normal screening test, then the recommendation is to screen them every 3 years, unless, of course, they develop symptoms or new risk factors that might suggest that they should be screened earlier. And an important consideration, there are point of care A1C tests, as you might be familiar. Those are not recommended to be used for the diagnosis because they're really not accurate enough to make that diagnosis carefully. And of course, the implications of diagnosing with someone with diabetes or prediabetes is significant. We want to make sure that they truly have it. So the other areas around screening has been in relation to pregnancy and preconception. And so again, we know that many individuals have pre-existing diabetes that are not diagnosed. And so the recommendations now for the first time are, first of all, in a planned pregnancy, one should think about screening probably all women, but certainly women with risk factors at their preconception visit. If they did not get screened at preconception and they are pregnant, at their first prenatal visit sometime before 15 weeks, they should also be screened for pre-existing diabetes. Previously, the situation was people were getting, women were being screened as usual for gestational diabetes 24 to 28 weeks, but they may have had pre-existing diabetes that whole time. And so these guidelines are aimed at capturing those individuals so they can get the appropriate treatment and have healthy pregnancy outcomes. The last area I want to talk about in terms of screening is around type 1 diabetes. And I'll talk more about type 1 diabetes in a bit when we talk about individualizing care. But one of the things that we detailed are the considerations of when you should be thinking about someone having type 1 diabetes versus type 2. And that really is, as you might imagine, certainly having diabetic ketoacidosis makes one think of type 1 diabetes, age less than 35 being the cutoff, and BMI less than 25. Any of those things should make one think about the presence of type 1 diabetes and to screen for that. In addition, first-degree relatives should be counseled around their risk of developing diabetes, and some of them should be potentially screened But the important consideration here is that we don't want to screen these individuals without the appropriate support. Understanding not only the screening for diabetes, but the screening for antibodies that can be predictive for the development of type 1 diabetes should be done either in research settings like TrialNet or in situations where the appropriate counseling is available so they understand their risk if they're antibody positive. Okay, so that was the screening, and you can see there's a lot of information there. Next, I'm going to talk about individualized care, and I'm going to talk about both that in the world of type 2 diabetes, but also in type 1 diabetes. And this is an effort that really, for those of you that have been following the diabetes field for a number of years, it's really the direction we've been going in terms of managing diabetes, that one size does not fit all. And let me give you some more detail now around that. So when we think about treatment for type 2 diabetes, you'll see as I share the algorithm, it's really individualizing that treatment based on 5 considerations. First, comorbidities, and specifically atherosclerotic cardiovascular disease, the presence of congestive heart failure or diabetic kidney disease. So it's comorbidities. Then it is also the risk of hypoglycemia and the dangers of hypoglycemia, weight, and then an important consideration, unfortunately, is access and cost of treatment. It's important when those are limiting factors, and we wish that they weren't, but our standards are really recognized globally. And so many countries don't have access to the right or the best treatments. And sadly, that's true here in the US as well. So some consideration there. And then finally, in terms of efficacy of the different treatments, and I'll walk you through how this is thought through with this algorithm. This one diagram in one page tries to pull together really everything you need to know about initial treatment of type 2 diabetes and the algorithm accordingly. And it does what I sort of described just a moment ago. If you look on the left-hand side here, the first step is understanding, do individuals have one of these 3 comorbidities? Atherosclerotic cardiovascular disease, or at high risk of that, congestive heart failure, or chronic kidney disease. If they do, they already moved to that side of the algorithm, and we'll talk about that in a moment. If not, then one can start thinking about these other considerations and the ones that I described: weight issue, risk of hypoglycemia, weight issues, and access and cost of treatment. So we'll work through a case to think through how to apply this, but I want you to just take a look at this and make a mental snapshot of it. So let's use a case, because I think often that's the easiest way for us to make this all real. So let's meet Edward. He's a 45-year-old gentleman who comes to you because he's checked his blood glucose with his mother's glucometer, and his morning levels are in the 200 range. He then gets assessed and gets an A1C performed. He also already has a history of coronary artery disease, is on aspirin, which, as you know, is recommended as secondary prevention in diabetes, and also on a statin, atorvastatin, which is again recommended for both primary and secondary prevention, and lisinopril for blood pressure. He is obese with an elevated BMI. So here's where you get to participate. So what's the first line of diabetes management for Edward? And throw your comments in the chat or write it down on a piece of paper, and then I'll walk you through the algorithm so we can think through this. But start throwing in ideas. What do you think? What would be the first line of management? Give you a moment to start throwing that in the chat.
We're getting a lot of metformin, GLP-1s, lifestyle, SGLT2s.
Great. All reasonable considerations. And so let me use this as a springboard to think through. So I magnified that image so that we can see it a little bit easier. So first line therapy depends on comorbidities. And that really is the key here. And one of the changes that is in the 2022 recommendations. And then there are those other considerations. But note here that it says it generally includes metformin, but does not have to include metformin. Previously, it was always metformin first and then think about what else. In this case, there may be, and you can see here in blue, these treatments for these comorbidities, and I'll go through these 3 comorbidities in a moment, are recommended independent of their benefit of the baseline A1C and also independent of the use of metformin. In other words, one could use these therapies without metformin. So that is a change. Now, let me walk you through the treatments of these 3 comorbidities. So the first one on the left is the presence of atherosclerotic disease or indicators of high risk. If that is true, one right away thinks about this part of the algorithm, and it's really GLP-1 or SGLT2 as therapy. And here's something new that was added, is that not only should we consider those drugs, but if after starting one of them, A1C is still elevated, not a target, consider adding the other, because there is evidence that they both are effective in combination. So that's something new. If the individual, on the other hand, has heart failure, really SGLT2 is the lead drug to consider. Doesn't mean you cannot use metformin, but they should be on an SGLT2 because of the proven benefits of that. Now, I didn't mention in this individual whether his MI and coronary artery disease led to congestive heart failure, but that would be something important to know because that could dictate therapy. I also didn't share in terms of his presence of CKD, but I'll walk you through this part of the algorithm. So CKD with albuminuria greater than 200 or without albuminuria have 2 sort of ways to go. And let me show you what that part of the algorithm looks like. So here is really where we're thinking about use of SGLT2 as a primary drug, either the ones that have been shown in CKD progression studies or cardiovascular outcome trials to be beneficial, or a GLP-1. And you can see again, there is benefit of combination therapy here. So now that we've gone through that algorithm and we've talked through a little bit, again, feel free to amend your responses or stick with what you had. But what do you think is the first line of diabetes management for him? So throw it into the chat and let's see what we have. Don't be shy.
We're having a shift to GLP-1s.
Ah,
still
gotcha.
Metformin. Some people are still holding on to metformin plus GLP-1, as GLT2s are popping up as well.
Yeah, perfect. No, and that all makes sense. And, you know, the GLP-1 has the added advantage in this individual, given that he is obese, to have weight benefits. So that, and we did not. Now, if I told you he had congestive heart failure as a result of his coronary disease, that shifts us again to the SGLT2. So very good. And of course, you know, we did not say, but it's important to highlight that lifestyle management and diabetes self-management, education and support should be another part of that first line therapy. Okay, so This is where most of you landed to work on one of these two, either GLP-1 or SGLT2 in this individual. So very good. One of the other things, a wonderful reference that are in the standards is this table that highlights all of the different medications for type 2 diabetes and describes them in those different categories that I described at the beginning that we use to determine which therapy is best. And in particular, you'll see there's a column now around efficacy because not all agents lower A1C equivalently. And so that's an important consideration with someone that has an elevated A1C. You may want to start, for example, this individual with an A1C of 9, they may benefit from 2 drugs at once to be able to bring them down, because most of these medications are 1 to 2 point A1C droppers, some even less than that, in which case that's an important consideration. So this is a good reference, and for, particularly for you early career individuals, this is probably something I would think about studying and committing to memory, because it's all right there. So let me now shift. We talked about individualizing care for type 2 diabetes. Let's talk about type 1. And so here we have a recent consensus report that talks about the management of type 1 diabetes. And this was a joint effort by us at the American Diabetes Association and our European colleagues, the European Association for the Study of Diabetes. And again, highly recommended for those of you that manage individuals with type 1 diabetes. It really is a wonderful document that talks about lots in the management of type 1 diabetes, diagnosis, treatment, et cetera. But I'm going to highlight some of the important things that we pulled into the standards of care. This table, again, gets this idea of individualizing care, and it talks about the different types of insulin regimens one can be on and the different types of insulin pump regimens one can be on. And for each of them, it talks about which ones are most flexible, which ones in terms lower the risk of hypoglycemia, and also the ones that have higher costs. And it starts with what you're probably most used to, and that's a long-acting insulin analog as a basal insulin, and then mealtime insulin with either rapid-acting or ultra-rapid insulin. And you can see that, but now it also talks about using NPH insulin with rapid acting, or NPH and regular insulin, or split insulin NPH analogs. So again, you get the choices and the relative merits of each of those. Similarly, we have that for insulin pumps, and the ones that again allow the most flexibility, have the lowest risk of hypoglycemia, but are of highest cost, are these hybrid closed loop systems. The low glucose suspend is the next option, and then not any automation associated is the third option. So again, allows one to individualize treatment for type 1 diabetes. And this is something new that had not appeared in the standards of care previously. The other tables that are helpful as references are these that you'll see in the chapter. And what they do is they take each of these regimens and give you more detail about why why they're rated the way these ratings are, and gives you recommendations on starting doses and how to make adjustments. So again, a useful reference. The other aspect that is covered for the first time is around beta cell replacement therapy. And as you know, there's some very exciting work going on in this arena. We've long had the availability of both pancreas and islet cell transplants, and these are recommendations on identifying what option to use. And you can see that it really is based on the presence of severe chronic kidney disease or not. And if it is present, then one wants to think about either simultaneous kidney transplant or kidney transplant from a live donor, and then follow up by a either pancreas or islet cell transplant. And then these are the indications for individuals without kidney disease, without significant kidney disease, to potentially get transplantation. And really, these are sort of failure of medical therapy that despite the best regimens that we can use, they continue to have severe hypoglycemia, ketoacidosis, progression of complications, etc. Okay. So we're about halfway through here of the 4 different highlighted areas. So this is a picture. I'm here in Boston, and is not what Boston looks like right now, but we have a place called the Public Gardens. It's a beautiful place, and this was taken in the spring. So I'm dreaming of springtime because it's about 20 degrees out right now here. Okay, so we're going to now move to comorbidities. We talked about screening and individualized care. So this figure, which is brand new, and I think you'll see reproduced a lot of different places, is a great way for us to think more holistically about our patients with type 2 diabetes in particular. And it's about reducing diabetes complications. And it starts with a foundation of lifestyle modification and diabetes education. And then there are 4 pillars to be considered. The first is diabetes and glycemic management. And of course, that's an area we've always been focused on. But it highlights for clinicians the idea that blood pressure management is also really important, as is lipid management, also really important. And the 4th column here is using agents with cardiovascular and renal benefit. And that gets back to the algorithm that I showed you earlier on that sort of said, if you've got those risk factors, those comorbidities, you need to be on the medicines that we know can prevent progression of either cardiac or renal disease. So again, the big picture of taking care of people with type 2 diabetes and preventing complications. The other new consideration was the rationale for combination therapy of both SGLT2 and GLP-1 to lower cardiovascular and renal complications in those that have established risks. So again, not only using one of those, but using those drugs in combination. The next is an emphasis on reminding people of the different goals and the different considerations early in the course of diabetes, where the targets, for example, for glycemic control are lower because of legacy effects and maximizing benefit. And then later in the disease, where people may have multiple comorbidities and A1C goals might be a little bit higher. So your therapy is really based on those considerations. Again, individualizing treatment. The other thing we did this year is that we, in the past, had a section that put together all of microvascular complications in one. And because chronic kidney disease, there's better treatments for this, and the number of individuals that are not getting those appropriate treatments is so high, we called out as a separate section chronic kidney disease, and I'll highlight what's new there. The first thing is really to think about albuminuria as an important parameter in understanding chronic kidney disease. And those individuals that have macroproteinuria, in other words, albumin greater than 300 milligrams per day, for the first time, we established a goal to say that albuminuria should be lowered at least 30%. So that's one big change. The other is the new medication, finerenone, is recommended in individuals that have albuminuric diabetic kidney disease to reduce both chronic kidney disease and heart failure based on recent evidence and studies over this last year. And then the final thing is, and this is particularly for our primary care colleagues, to think about not only GFR, but albuminuria to categorize the state of an individual's chronic kidney disease. Because as we showed earlier, their management really depends on both factors, GFR and albuminuria, and they should be monitored regularly. We also highlighted some aspects of management of other comorbidities. The first, of course, is COVID vaccination, and the recommendation, of course, for all people with diabetes to be vaccinated. The guidelines did not include boosters because they were published and finalized before all of that information was out. But of course, we align with the Center for Disease Control on that. The other important section worth reviewing is around liver disease and diabetes. This is one of those unsung complications of diabetes. Diabetes is now becoming the leading cause for liver disease. Both NASH and NAFLD is increasing. And so there are recommendations both for screening and diagnosis of these, in essence, complications of diabetes, particularly in people with type 2 diabetes, and also some treatments. And as you probably know, there are a number of therapies that are in the pipeline that are nearing FDA review that may change our management of this complication significantly. The last comorbidity that I want to highlight is the issues around cognitive capacity and impairment. So increasingly realization that diabetes is increasing the risk of cognitive impairment. So we need to screen for that, and we need to adjust therapy appropriately for the presence of cognitive issues. So we've done 3 out of the 4 major themes, and we're going to get to that last one. And again, put any questions in so that we can answer them in the next few minutes. So let me now, we talked about screening, individualizing care, comorbidities, and the last one is glycemic assessment and technology. And that starts around glycemic targets. This figure should be familiar to you. If not, it is really important one, particularly for our early career colleagues, to have emblazoned in your brains. And this identifies the different buckets, particularly for continuous glucose monitoring, where the different buckets of glycemic measurement are and what those goals, established goals are. So you have that information here. And then some new information that describes, first of all, that typically in managing individuals, we're going to use 14 days of CGM data to look at their time in range and time both above and below range to be able to understand how they're doing in conjunction, of course, with A1C. But for the adjustments, it's really going to be the last 2 weeks that are probably going to be the most helpful in making treatment recommendations. We also got rid of the term self-monitored blood glucose because that's no longer really applicable, and changed that just to blood glucose monitoring because that really is what this is. And we talk about time below range and time above range, and that's really what one should use to direct changes in medical therapy. We also summarize the data that talks about time and range being associated with the risk of microvascular complications, and therefore is a valid assessment of glycemic control. And then finally, the presence of hypoglycemia is an urgent issue. And so when you're looking at all of those numbers and time in range and below range and above range, you really need to hone in on the hypoglycemic range. And based on that presence, one needs to think about what to do to reduce that, whether that's further education and then reevaluation or adjustment and treatment, because that is something that needs to be addressed acutely. So that's in terms of glycemic assessment. Let me finish up around diabetes technology. And so first, we highlight once again this idea of individualizing the device choice for individuals. So as you know, there are different continuous glucose monitors, and the choice should really be individualized based on the patient's need. And all people that have continuous glucose monitors should also have blood glucose monitoring capability. And so that is a signal in part to our payer colleagues. As you may know, payers look to our standards of care to make treatment coverage decisions. And so we wanted to highlight that it's important that people can continue to do blood glucose monitoring, either for calibration or as a way to validate an outlying blood glucose measurement on a CGM. We also make CGA recommendations for both real-time and intermittently scanned systems, and then we highlight the different levels of evidence for each of those. But this second item is really, I think, an important one. We talk about CGM use, either of the devices, for really all youth and adults that are either on multi-dose insulin or insulin pumps. Anyone that's capable of using these devices really should be offered them. And individuals that are on basal insulin alone, based on recent studies, also benefit from CGM, and those individuals should also have access to CGM, continuous glucose monitors. For those that require insulin, we make a clear statement that insulin pens are preferred. Of course, one takes into account provider and caregiver preferences, but this is the recommendation. And then finally, a discussion about the value of digital health solutions, mobile apps, simulators, digital coaching that can really be very beneficial for individuals with diabetes to help them manage their disease. So I've covered a lot of ground, but you may wonder, how do I learn more? And I have some great opportunities for you. The first is coming up on February 4th. We will have a clinical update course. This is really an incredible collection of the greatest speakers in diabetes. You can see the multidisciplinary team that makes up the course directors and really covers everything about the standards of care and the management of diabetes. And so I encourage you to register for this. It is all virtual. The information will be available after the meeting as well. So if you cannot attend during those dates, that's fine. You'll be able to view it afterwards. So that's one opportunity. And the other is a really concerted effort by all of us at the American Diabetes Association to make sure that people understand the standards of care and can implement them, make them actionable. So along with the full version that's available on the website, there's also an abridged version available for primary care providers. I encourage you to download the free app that has a number of the key figures and that are interactive, and some of the figures that I showed you here, they become quick access to you on your phone while you're literally seeing patients. There are also pocket cards available. There's a webcast that's available online for free with either continuing education credit or without, up to you. And we'll be developing some new visuals infographics to take all of this information and make it user-friendly. So with that, I'm really pleased to be able to share all this information with you. I hope to see all of you in New Orleans coming up for our annual meeting. For those of you that have not attended the Scientific Sessions meeting, if you go to one diabetes meeting a year, this is undoubtedly the one. This is the Super Bowl of diabetes. So hope to see you all there. We're planning on being in person. There will also be a virtual component, but we're, fingers crossed, going to be there in person in New Orleans. So looking forward to seeing you. And we now have time for some questions and discussion. So thank you all so much. And let me just end with one comment. You know, I also continue to see patients, and I see the gaps in care every time I go, and it's really all of you in the audience that have the ability, the power to change that. And so I thank you for everything you do for people with diabetes, and recognize that it's not easy. And managing diabetes takes a certain temperament and personality and commitment. And I thank all of you for having those elements. So with that, glad to answer questions.
All right, thank you, Bob. That was wonderful. So we have a lot of questions, so we will try to group them as much as possible. There are a couple of questions about the point of care. And one question is, someone thought that there's an FDA-approved point of care A1C that is a good fit for diagnosis. That was one. And on the same line, someone just requested a little bit of more detail of why no point of care for diagnosis.
Yeah, it's a great question. And so there was a recent scientific review published by the American Diabetes Association that really details this for those that have a particular interest. But bottom line, you know, for use beyond diagnosis, certainly point of care is extremely valuable because the cutoffs for the diagnosis are quite sharp. The accuracy was not deemed to be good enough for diagnosis. So there are devices that are approved for management of diabetes in essence, but not for diagnosis. And these are generally CLIA-waived devices that do not meet those standards. So it was a rigorous evaluation by the group that came up with that consensus report. And for those interested in more, that was released in this last year in Diabetes Care, and it will give you more detail.
Thank you, Dr. Kubay. So there is a question, and also it's a theme, why not metformin as first line? Why is it now generally, but not metformin?
Yeah, well, you know, I'm glad you asked that, because this was a big discussion, and the reason the recommendations, the Professional Practice Committee and the rest of us thought that this was the right thing to do is if you have one of those three comorbidities, high risk or atherosclerotic disease, chronic kidney disease, or congestive heart failure, those individuals benefit from these treatments, non-metformin treatments, specifically SGLT2 or GLP-1. And we did not want to deny those individuals that treatment, because what often happens is because of some degree of therapeutic inertia, people get started on a drug and it's a long time before they get to that next drug. And so as opposed to a stepwise approach where people would not be on these medications, which we now realize are life-saving, if you have those comorbidities, think about those treatments right off the bat. Could be in combination with metformin, fine. If you don't have those three comorbidities, then sure, metformin first line makes sense.
Excellent, thank you. And we have a lot of other questions, but another question, you know, it's really a series of questions about the type of screening in early pregnancy. You know, what do we specify at ADA? You know, along these lines, many questions, but we'll start with that.
Yeah, so the when we're talking about diagnosis and the new information around diagnosis in pregnancy here, just to clarify, that's diagnosing pre-existing diabetes. And so the criteria are really the same ones that we use to make the diagnosis in non-pregnant women. Uh, then there is a second point of screening, and that's what we've traditionally done and is longstanding, and that is 24 to 28 weeks for gestational diabetes. So there are two screening points, one for pre-existing diabetes, either in the first prenatal visit or in preconception counseling. That's the new piece. And then the traditional piece is the gestational diabetes screening process.
Perfect. And another question is, I think our use of the word women means childbearing. There's just somebody's clarifying, and this applies to LGBTQ individuals. Just a clarification.
Oh, thank you. Thanks for that clarification. Yes.
Yeah, so that was a question. And there is a question about initiating metformin and GLP-1 at the same time to maximize benefits. Any thoughts?
Yeah, I think that could very well be an appropriate treatment, particularly someone with an elevated A1C, because we know that one drug and either of those are going to do 1 to 2 points at best in terms of A1C. So to get an individual to goal, they may benefit for both therapies at once. And certainly if they have atherosclerotic disease, one certainly will want to use, and obesity, one will want to use a GLP-1 treatment, but that may not be sufficient to get their A1C down, and therefore both therapies could be the right choice.
Another clarification, I mean, because people are asking about the point of care A1C in diagnosis. I think just to clarify that, the guideline is specifically talking about diagnosis, not follow-up in clinic, because I think some people are confused with the recommendation.
Yeah, no, that's an important thing to highlight. We're really only talking about for diagnosis of diabetes. Once someone has diabetes, using a point of care test to decide how to manage them and to see how their A1C is, totally appropriate and quite helpful because as many of you know, one of the wonderful things to do is to have an A1C when you're seeing a patient and be able to make treatment decisions right then, as opposed to seeing the patient, ordering the A1C, and then getting the result after the fact. And that's where point of care testing can be really helpful in the management of diabetes.
Perfect. And we'll pivot a little bit to prediabetes. There are questions about the use of glucometers in prediabetes and the use of GLP-1s in prediabetes and our stand as ADA.
Yeah, so the recommendations have not gotten to the point of saying, number one, these individuals should be treated with GLP-1. Metformin is the preferred drug and what has the greatest evidence. Lifestyle is the most effective therapy for people with prediabetes. And again, this is based on the diabetes prevention program, where lifestyle was almost twice as effective as metformin, but metformin was effective as well. So those are the recommendations for prediabetes management.
There's a thoughtful question that's asking if you anticipate that payers will follow the metformin recommendations and remove PA requirements of prior authorization use for other newer medications.
Can you clarify that? Do you think they're speaking of in the management of diabetes or pre-diabetes?
In the management of diabetes, do you think PAs will be less now to the newer medications?
Yes. Well, so it's a great question, and it's an area that one of the other things the American Diabetes Association is really active in is around advocacy, and so we work with the payers around the country, both commercial payers and governmental CMS to advocate for all of these things. And our experience has been that step one is to put things in the standards of care, because often that is what formulary committees at different payers use. And so our hope is that in fact will happen, that this will be more widely recognized as early therapy for individuals with those 3 comorbidities.
Thank you. There's a question, there are 2 process questions for the guidelines. So one is, do we have a process, or do we plan to have a process to involve people with diabetes as a part of the update and creation of the guidelines?
That's a great idea, and it's something that we've thought about. The challenge is that the discussions around these guidelines end up being highly technical, and Nuha, you feel free to chime in here. Literally, there are hundreds of hours of discussion, and they get very detailed and technical, specifically the studies, the number of individuals, the inclusion-exclusion criteria. And so it makes it a little challenging for non-trained individuals to join in that discussion. What we do, however, is that our board of directors that approve the standards are made up of both professionals, but also non-professionals, and many of which personally have diabetes.
Thank you. So we have some clinical questions. One is strategies to minimize GI effects with GLP-1 receptor agonists now that we are recommending them.
Yeah, so certainly one of the limiting factors for the use of these treatments are GI issues, and part of that is mechanism of action, right? It's delayed gastric emptying, so that leads to satiety and decreased food intake, and there are also central effects of GLP-1 agonists as well. Probably the most successful thing is starting low and going slow. An old adage that we think about in general, but really true here for GLP-1 agonists, and also true for metformin, where we've long used that slow, gradual increase in dosage. So I think also warning individuals that they may experience some symptoms, but that those symptoms often do get better over time. And so they may first time have symptoms, but if they can stay with it, and again, it's all a matter of how bad those side effects are, that it typically does get better. So combination of warning individuals that this may happen so that they're prepared, and then only slowly titrating up the dose.
Thank you, Bob. And another question, one of our trainees has noticed that metformin use in GDM, gestational diabetes, is actually more often. Is there a time when you would actually have a patient go on metformin and not insulin?
It's a controversial area. We did not come out in favor of its use as a standard use. That said, could there be times? Yes, there could be, and it's a matter of weighing risk benefit. We have lots of data on the impact of lifestyle and insulin. The use of metformin less so.
Perfect. So we have, I believe we have 2 minutes left. So I believe we need to wrap up. I think there was one last question that was asked over and over: is new glucagon on the market? Type 1s are using it to raise their blood glucose, and that is causing a lot of hyperglycemia. Any comment on this off-label use?
Yeah, I'm not. I'll say I'm not a big fan. I think it's a treatment for emergency use with significant hypoglycemia. I think that is the best use for it. That's what's FDA approved. The one thing I will comment about its use is it is incredibly prescribed. So if we recently looked at some data of individuals that had a emergency department visit for hypoglycemia, and only a minority of them end up getting a prescription for glucagon, and every one of those should have one to prevent that from happening in the future.
Thank you so much. And I think diabetes education, biggest thing.
Yes,
we will leave everyone with. Yeah,
very important.
Yeah, thank you very much, Bob. So this concludes our session today. We would like to thank you for a great presentation. For everyone, please join us on our next session, January 21st. It will be focused on job interviews. So we don't just do clinical, we also do other things in professional development. And don't forget, if you're not a member of Focus on Fellows, please do apply. We did provide the link in the chat. Thank you again to the Leona M. and Harry B. Helmsley Charitable Trust for their support for today's program. I also want to thank each of you for joining us and for making the time to be with us today in Focus on Fellow participants in all the webinars. This concludes our program today. Thank you again for your time, and we look forward to connecting with you at the next Focus on Fellow program.